Now, in the fifth and final section, we will talk about the emergency procedures. Some emergency procedures which can be performed are the jaw thrust and oropharyngeal airway, laryngeal mask airway and cricothyroidotomy, percutaneous dilational tracheostomy. So these are all the emergency procedures that can be performed for the management of the airway. First procedure for immediate airway management. Jaw thrust, very important. Jaw thrust is the procedure that can be performed for CPR also, which is the cardiopulmonary resuscitation. Jaw thrust helps the person to breathe easily, to maintain the airway before any other procedure can be performed. So jaw thrust, which is lifting the jaw upward. Here you can see that's the position of the hand with the fingers on the sides of the jaw, and it is upward, lifted upward to make the airway straight so person can breathe easily. So lifting jaw forward. Extending neck improves airway. It causes displacement of the soft tissue to remove any obstruction that can be obstructing the airway. Neck extension is avoided in spinal injuries. So if the patient is injured, if there is airway obstruction, the first step sometimes is the jaw thrust, in which the neck is or jaw is lifted forward, and neck is extended. That removes displaces the soft tissue so breathing can be done. And if there is any spinal injury expected or suspected, avoid the jaw thrust because it can exaggerate the injury to the neck. Oropharyngeal airway displaces the tongue anteriorly, relieves soft tissue obstruction, ventilation can be carried out, and ambu bag is used in this. So these are two procedures which can be used for maintaining the airway in emergency. Then we have a nasopharyngeal airway. Nasopharyngeal airway, this is the trumpet, which is the easy method for maintaining the airway, nasopharyngeal. This is also the trumpet is inserted transnasally in the posterior hypopharynx. Relieve soft tissue obstruction. Better tolerated than oropharyngeal airway. So oropharyngeal from the mouth into the pharynx. Nasopharyngeal is from the nasal cavity into the posterior hypopharynx. And this is better tolerated than the oropharyngeal airway method. It is done in patients who are awake. Then we have endotracheal intubation. That's the endotracheal intubation. Most rapid method. Larynx observed with laryngoscope. So larynx is observed with laryngoscope when we do the intubation. Endotracheal tube or bronchoscope is inserted. No anesthesia is required for endotracheal intubation. After intubation, orderly tracheostomy is performed. So now in emergency situation, we said we can do the jaw thrust, oropharyngeal airway, nasopharyngeal airway, then endotracheal intubation. Most rapid method, The larynx is observed when the intubation is performed, and then after the intubation is performed, we can do the tracheostomy. Next, another method is laryngeal mask airway for the emergency procedure. Device with the tube and triangular distal end which fits over the laryngeal inlet. Here, the distal triangular device which fits on the inlet of the larynx. This is the device which is known as the laryngeal mask airway. So it's a device with the tube and a triangular distal end that fits over the laryngeal inlet. In this, oxygen is delivered directly to the trachea with the laryngeal mask airway. It is used for non-emergent airway control, and it is used when mask ventilation is inadequate and intubation is unsuccessful. So, laryngeal mask airway is used when the non-emergent airway control is required, mask ventilation is inadequate, and intubation is unsuccessful. Then transtracheal jet ventilation. Transtracheal, through the trachea, transtracheal jet ventilation. What is this technique? It's an invasive procedure in which the intravenous catheter of 12 to 14 gauge with syringe attached to that is inserted in the cricothyroid membrane. So it's the invasive procedure in which the catheter with needle attached to it is inserted into the cricothyroid membrane. Needle is removed, the catheter remains inserted. The needle withdrawn, leaving catheter in position, jet ventilation started. So this is transtracheal jet ventilation. Thin individuals is easy to insert. Individuals who are obese with thick necks, it's hard to insert, should be avoided. Expiration of air is ensured. Barotrauma with pneumothorax, pneumomediastinum, surgical emphysema can result. So these are all the complications associated with transtracheal jet ventilation. Cricothyroidotomy or laryngotomy. Now, cricothyrotomy, otomy is the opening. So in this, the opening is in the cricothyroid cartilage or membrane or in the larynx, laryngotomy. A procedure for opening the airway through the cricothyroid membrane. Patient head and neck is extended. Here you can see the opening is in the cricothyroid membrane. Identification of lower border of thyroid cartilage, cricoid ring is done. Here you can see neck is extended. This is roughly the area for the skin incised vertically. Cut is given in the skin vertically. Cricothyroid membrane transverse incision is given. Kept open with the tracheostomy tube, orderly tracheostomy done at earliest. These are different steps or procedures we are talking about when we need emergency airway management. So these are different procedures that can be performed. But so far we know that endotracheal intubation rapidly along with the tracheostomy later on, is the most recommended procedure in emergencies. Next, mini tracheostomy. It's an emergency procedure to buy time to allow patient to be carried to operation theater. So when we need time to carry the patient to the operation theater, we just perform the mini tracheostomy so to help the patient to breathe. Commercial emergency kit is available. It's an elective procedure to clear bronchial secretions following thoracic surgery. Cricothyroid needle puncture, a procedure where large bore catheter is introduced through the cricothyroid membrane. Here you can see the diagram of the procedure. An emergency procedure, ill patient can be intubated or tracheostomized. So this is the condition in emergency in which large bore intravenous catheter is introduced through the cricothyroid membrane. It's an emergency procedure. Not provide adequate ventilation, but it can be done in emergency before the tracheostomy can be performed. Emergency tracheostomy, neck is extended. Now the steps, the neck is extended, trachea identified and fixed. Vertical incision is given from lower border of thyroid to suprasternal notch. Lower border of cricoid cartilage is identified. Transverse incision is given in pretracheal fascia. Thyroid isthmus dissected to expose upper 3 rings. Vertical tracheal incision in second and third ring is given. Open with hemostat and tube insertion is done. Bleeding, if is present, can be controlled by packing with the gauze. So all these are steps for emergency tracheostomy, identification, incision, then putting the tracheostomy tube, identification of cricoid cartilage and the tracheal rings, and then packing if there is any bleeding present. Percutaneous dilational tracheostomy. What is this? It's done in intensive care unit when patient is intubated already. Under sedation, neck is extended. Neck is prepared and draped. 1.5 to 2 centimeter incision, 2 centimeter below lower border of cricoid is given. Trachea exposed by dissection and palpation. Small caliber flexible bronchoscope is inserted. Entry into the trachea between second and third ring. So this is the percutaneous dilational tracheostomy. In ICU, if patient is already intubated, small incision is given and then the catheter is inserted. Small caliber flexible bronchoscope is inserted to enhance the ventilation that can be done. Advantages are the no need to transport patient to operation theater, avoiding operation theater expenses, avoiding ICU nosocomial infection to be carried out to operation theater, and earlier discharge of patient. Contraindications are obese, having neck mass, difficult to intubate, difficult to extend neck, larynx and trachea not easily palpable, and uncorrectable coagulopathies. All these are contraindications and we should not perform the procedure. Complications: paratracheal entry of dilator or tube in the lumen, hemorrhage, damage to posterior tracheal wall, surgical emphysema. So that concludes our topic, airway management, in which we discussed in detail tracheostomy, some other emergency procedures for airway management, types of tracheostomies, complications, indications, functions of tracheostomy. So that concludes our topic, airway management. Thank you for watching sqadia.com.